Howdy y'all, I'm Dr. Jeff Jarvis. Welcome back to Q1CE. Hopefully y'all have already watched the segment where Daniel and Allison covered what Syncope is, how we measure our performance around obtaining a 12 lead for Syncope patients, and why it's important. We're now going to a discussion I had with Dr. Maya Dorsett while we were both in Southern Oregon speaking at the State of Jefferson Conference. I just got to put in a minor plug for that conference. If you ever get a chance to go to Ashland, Oregon, it is one of the best conferences in the nation. It's truly great people, great conference, great content. And as an added bonus, you can go see, say, the beautiful Crater Lake. It is really a gorgeous part of the nation to go visit. Now, because this was a remote location, I had to use some mobile recording equipment, stuff I could easily take with me on a plane, fully aware of the havoc that my typically bad travel luck could induce on my equipment. What that means is I was using portable lapel mics and on my iPhone and a much smaller camera than I typically use. Now, as a result, the video and audio quality isn't what I like. It's not like this setup I have here, but I think it is clear enough for y'all to get the full effect of the Maya goodness. So the topic of why we do a 12-lead ECG for Syncope, it's an important one because we have the potential to truly make a difference in the life of a patient and in that patient's family. I think many of y'all have met Mike Verkest. Mike is our new clinical practice coordinator who works with our MIH and critical care teams. Well, Mike and his wife, Michelle, lost their son, Caleb, to sudden cardiac arrest. He had no indications of any cardiac conditions, much less a potentially life-threatening cardiac abnormality. Unfortunately, Caleb had a condition called arrhythmogenic right ventricular cardiomyopathy. That induced a lethal dysrhythmia and cardiac arrest. Arrhythmogenic right ventricular cardiomyopathy is one of the conditions that Dr. Dorsett is going to tell us about. If Caleb had ever had an ECG and had someone who knew what to look for, they might have been able to identify this condition and allow him to get treatment and live a normal life. This is just one example of why we should do ECGs for patients who have syncope. Let's hear what Dr. Dorsett has to say about the role of the ECG in helping us identify some dangerous causes of syncope. This segment is mandatory for paramedics and critical care paramedics. It's great content, so I encourage everybody to watch it, but I want our EMTs to know it's optional for them. Dr. Dorsett.
Maya, thank you so much for sitting down and talking about some really cool stuff. So the two of us are here in Ashland, Oregon at the State of Jefferson Conference. This is a conference we come to quite a few years. 2 years ago, I sat in on a lecture that you did about common causes of syncope in young people, which was what you intended the lecture as. And what I heard was this is a great way to discuss the things we're looking at with a 12-lead ECG when we have a patient that has a syncopal episode. Now, we should do this for all of our patients, regardless of the age. The significance here, I think, is probably most important in young people, but it's there for all people. So let me just give the folks in Fort Worth an idea of who you are. We've worked together on, I have lost track of how many committees.
Many things.
Many things. You are the medical director for Prodigy EMS, do some great content there. You are also an associate professor at the Division of Pre-Hospital Medicine, Department of Emergency Medicine, University of Rochester. That is Rochester up there where it's really cold, where the southern border is you. You're under the southern border, and which in Texas has a completely different meaning. You are also the Associate Regional EMS Director for the Monroe-Livingston EMS system up there in the far north part of the country where it gets
Southern
really
Canada.
cold. Southern Canada,
Yes.
that's it. We have been referred to as Southern Oklahoma by people who really don't know any better. So Maya, you're going to talk to us about 12 leads. So what you got for us? Why should we do 12 leads in patients with syncope?
And then we're focusing on young people, which is what you brought in. And I think part of the reason that it's important to focus is if you look at your entire practice, you say, what are the gaps? Like, what are the things that we don't tend to think about? And I think I started focusing on this because most of the time when a 70-year-old passes out, people are like, I should do a 12 lead when a 70-year-old passes out, because we were taught in our education, right, to look for things like heart blocks or signs of ischemia or a big PE or any of those things. And I'm going to just say that's not what we're going to be talking about today, because I think that is an ingrained part of education, particularly at the paramedic level.
Yeah, I think if they passed out because they're in a third-degree heart block, I think you're probably going to pick up on that.
Yeah, usually by this, right? Like I just, right.
Well, that's like, one way, right?
Like,
yeah.
Right, like you're gonna suspect that something is off by your physical assessment, and you're gonna get.
I don't understand though. You touched the patient.
I know.
Crazy. The way you get a heart rate is by looking at the pulse oximetry.
Like, what are you trying to do to me? I'm like, I'm just trying to feel your pulse, Jeff.
You can never tell with these New Yorkers. So. STEMI. I think we frequently think we're looking for a STEMI because that's all a 12-lead ECG can tell us. So that clearly must be what caused the syncope. And so my two things are that hypoglycemia and STEMI almost never, by definition, cause syncope. Unless you pass out from your hypoglycemia and impale yourself on a glucagon autoinjector.
Yeah, because you're still out of it.
You're still out of it. There is no brief and transient and fully recurred. Likewise, a STEMI is not going to go away. I mean, I guess you can dislodge a clot if you fall. I don't see how that would work.
Yeah, and usually I'm going to show you some interesting stuff where you can actually break yourself out of deadly arrhythmias, but the VFib of a STEMI is not usually that one.
Very good.
Different pathology. So I just wanted to give that a little bit of a context, because this is really a talk about the deadly causes of syncope in young people, but I wanted to give an explanation of why I focus predominantly here, because I think this is an area that if we filled the knowledge gap a little bit, we empowered people to change a patient's trajectory of care, the impact in life years is huge, and you cannot find what you do not look for. And I actually want to start with a couple cases that happened honestly within 6 weeks of each other in the system. And I call this kind of like a tale of two cardiac arrests. And the first case was a dispatch for a patient in their 20s, like a young woman, and the patient was found to be apneic and pulseless and appeared to be incontinent. This was the call that came in. And the family heard the patient fall. They found them unresponsive and called 911. And there was not bystander CPR, but there was, in this case, a quick response time. And immediately, actually, this was a two-tiered system where usually fire gets there first, but just because of where they were, the paramedic and her EMT partner got there first. They initiated CPR, got pads on. This is the initial rhythm. It is subtle, but it may be appreciated. This is captured from the monitor data.
Very, very subtle.
Right? The initial shock and a single shock, and they got an organizing rhythm. And I'm going to pause here a little bit on this EKG, right? It's not the highest quality EKG that ever happened, but I want everybody to like pause and look a little bit, because what are the things we get EKGs in post-GROS patients all the time, and what we're looking for 98% of the time when we're getting an EKG, right? Usually, ideally after 8 minutes because of false positives in post-ROSC, is a STEMI, because when we think about VFib arrest, we're thinking a STEMI. And there are definitely things that can cause a STEMI or a STEMI-like presentation, such as like spontaneous coronary artery dissection. But there's not that many STEMIs that happen in 20-year-olds who have no other medical history. Like, this is not a patient who's had type 1 diabetes since she was 8 years old, right? This is not somebody with a huge other set medical problems. And so what we're looking for, well, we do look for a STEMI, is really we're getting an EKG to look for other causes or etiologies for that. And these are her vitals, which are pretty good vitals, I would say, immediately post-ROSC. This is her initial EKG. And what you might notice is that the QT interval is greater than 1/2 of the RR interval. This was
also notice the heart rate at 176 does not seem to be
correlated, right? That was the
Yeah.
charted heart rate, and that's the EKG. This was her first EKG in the emergency department, which was ventricular bigenotomy, which is just interpret this as pissed off heart.
That is exactly how I refer to it.
That is.
Yep, I'd be pissed too.
And then this is her subsequent EKG, right, when things are moving and slowing down a little bit.
Taking a few breaths and calm down now.
And this particular EKG has, if you actually calculate this QT interval, which we'll talk about, this patient had prolonged QT. And she was just got a defibrillator. It turns out
post-arrest picture here.
Post-arrest. This is the discharge to home, neurologically intact chest X-ray, and it turns out that this patient had a sister in the same year who had a cardiac arrest, unexplained, who died and was not resuscitated. Right, so like there was a family history when there was time to ask about it, and she had a genetic mutation, and we'll talk more about that had prolonged QT. Now, we also had 6 months later where you get a call of a dispatch initially for a seizure for a 5-year-old seizing in bed next to mom. That when the fire department gets there, they rapidly identify that what was interpreted as a seizure, right, abnormal breathing, was a 5-year-old in cardiac arrest, thereabouts. I've changed the ages a little bit.
Right.
Okay. They began CPR, they applied the AED, they had a single shock from the AED, which returned this patient into an organized rhythm, right? Like, big win. And this is that child's EKG, which you will also notice if we go through, right? Like, this is a sinus rhythm. You can calculate the heart rate, but what you're going to key in here is that if you look, I'm keying in. Like, one of the first things I'm always looking at is the QT interval. Is this patient had also genetic prolonged QT syndrome. This is his EKG when his ICU. And this kid, okay, also went home with a defibrillator and completely neurologically intact. And so we tend to think, because the majority of the patients who have significant cardiac abnormalities that we think about are older patients, and we think about a certain set of pathologies that happen there. There's lots of lives to be saved by actually finding young people who have some of these predominantly genetic issues, because if you can find them before they die, okay,
right,
you can prevent that from happening. So we're going to talk about 5 things, the deadly causes of syncope in young people, and I think about this in the 5 things every single time I have a young person, or really any patient that presents with syncope, but particularly a young person, right? I'm going to say, like, the vast majority of young people who pass out are like vasovagal, right? They're vasovagal episodes. They have a story for that.
Something benign.
But yes, something benign. But there are circumstances that we think are benign, but nobody ever checks, right? So, like, somebody passes out on the football field on a hot day, and we think, they were just dehydration. Okay, but as I'm going to talk about, there are certain pathologies that make you more predisposed to pass out on a football field on a hot day when you're dehydrated. And if nobody ever gets the EKG, the next time you pass out might be from your cardiac arrest from ventricular fibrillation in an athlete.
So I want to hit on, you have 5 things. Every time you evaluate an ECG in a syncope patient,
I look for these 5 things explicitly. This is my checklist.
So this is a great cognitive tool to avoid missing rare high occurrence or low occurrence high acuity things. So I would imagine when you see someone with a headache, you have a list of things that you're evaluating. That's some red flags perhaps. When you're evaluating somebody with chest pain, you have some red flags. Shortness of breath, red flags. So this approach to diagnosis, this approach to patient care is sort of classic in emergency medicine. We teach this all the time because there are things of high consequence that we don't see very often. We have to have these mental models where we don't overlook it. And I love the 5 fingers there. It's interesting, you picked an interesting finger for the one case, but we'll go with that.
All right. So the first one we've already talked about is prolonged QT. So let's actually talk about what the definition of prolonged QT and actually understand a little bit about
Are we going to get
disorder.
to do some math here?
Less math.
Oh, okay.
Some genetics, which...
Okay. I think I'd prefer the math.
It's funny, people assume that my PhD is in something related to what I do now, but my PhD is actually in molecular genetics.
Oh, good God.
And so this is one place where
I was
we
sort
get
of
to blend
hoping for
that.
archaeology or something fun.
That would be
That's
probably more relevant, yeah. And I just spilled water down my face.
See, New Yorkers all have drinking problems.
We do have drinking problems. All right. So the QT, right, if you think about what is the QT interval, really to actually calculate it, you have to take the slope of the T wave and go down to where it intersects the isoelectric line. And really you have to correct the QT for the heart rate. And so the QTC is the QT divided by the square root of the R interval. Nobody does that. And I'm going to say there's very few things that the automatic EKG interpretation is good for.
Yep.
This is the thing, okay? This is the thing that it actually will calculate the QTC for you as long as the quality of your EKG is reasonable.
It's clear.
Okay.
If it involves square roots, I'm out.
Yeah. But one quick thing, if you look at it, right, and you say, I actually look to see what is the QTC number, but when you're perfectly like looking at EKG, with the exception of bradycardia, where you can underestimate that visually, because the QT can be a lot longer in bradycardia than you think if it's greater than 1/2 the RR interval. But if it's greater than 1/2 the RR interval, you got to worry about prolonged QT. But look at the QTC. And in men, okay, it's greater than 440 milliseconds. If it's in women, it's greater than 460. I'm going to say the time I'm like, something is up here, then it's greater than 500. And there's lots of things that affect our QT interval, right? There are medications.
Don't you dare say droperidol.
The antiemetics, the antipsychotics, patients who are on amiodarone, like a lot of the different cardiac meds, right? They will all prolong the QT. But I want you to remember that it's like sometimes the 20-year-old is on some psych meds that can prolong your QT. They could, some medications for opioid use disorder, methadone will actually can significantly prolong your QT. And there's certain circumstances where these things interact with one another, but there's also genetic abnormalities that do this that we'll talk about. But the worry here, right, is the R on T phenomenon. And if you kind of think about it as like the organization, I always teach my students about the relative refractory period and the absolute refractory period by thinking about how the lights shut off and turn on and shut off in a room.
I go for toilets flushing, but
toilets
you
flushing.
Can see where my mind is.
Right, but there's this kind of space, right? Like if I first I have to turn on, right? Like the depolarization happened, everything's turned on, the lights are on,
right?
And then there's kind of this period where I'm coming, right? It's coming back before it's it's going totally off.
Your switch is moving, but you're not making the connection.
Yeah, right? It comes off and then it's slowly coming back, and there's this threshold before you hit it. And if you think things have to be organized, if I hit stuff when all the cells are in different places, then I'll get a disorganized electrical stimulus, and that becomes ventricular fibrillation, right? If you think about the normal depolarization and contraction of the heart, it is an organized process. So if some cells are in an absolute refractory period, some cells are in a refractory period, I have a potential to have a disorganization, and that's the RNT, right? That's the RNT phenomenon. That's the thing we're always worried about in cardioversion. When you prolong the QT interval, you increase, right, that time that that you can have a premature contraction of some kind that hits it and leads to disorganized depolarization. And
my favorite chart.
This is my favorite.
I love this.
I love this so much because I think if you understand the cardiac action potential and how it relates to the things that you see in your EKG, you can understand so much, right? It's the fundamentals. All the cardiac meds work via
Don't
this.
you just love Von Williams classifications? I love that. I think we're outing ourselves as pretty significant nerds here.
I draw this on chip, right? Every time I have a student or something with me, we talk about, like, I actually like think through the fundamentals. But if we think about the cardiac action potential, like go way back to whenever you learned this, right? Initially, I have sodium coming in. So if I'm a pacemaker cell, I have a rate at which sodium comes in until it hits a threshold potential. And then when I hit that threshold potential, right, I have this rush of sodium and then calcium. And the way the whole thing gets reset is that potassium then slowly leaks out. And so if I think about this in terms of ventricular depolarization, which is represented by the QRS, and the repolarization, which is represented by the T wave, if I change the cadence of this process in some way, I can either impact depolarization, but also impact the repolarization process. And this is just a screenshot from Wikipedia with not the goal that you realize, but these are all the genetic mutations that lead to prolonged QT. And
that's an extensive list.
There's a lot. It's not just one.
Right.
The majority of these are potassium channel mutations, which makes a lot of sense, right? Because if I mess something up about the potassium channel, I mess up that resetting of the depolarization gradient. Some of them are calcium and there's a few sodium, but they're all related to channels that affect this process. And so what ends up happening, right, is if I prolong the repolarization phase, I prolong the QT. And every time you see that, a prolonged QT, there's a change in how quickly I'm resetting the membrane potentials. So I'm going to pause here a second. So this is a video that I stole from The Lancet, and I think it's also, when we say syncope, I put seizure in that group, right? If you're out there and you've ever had somebody have a witness v-fib arrest in front of you, right? I think we've all been like, psych, it's not a seizure, right? Because somebody will tense up and you're like, oh, they're seizing. And then you're like, oh shit, they're dead. Like
it's a party foul. We really want to avoid that. Right. Yeah. The fib seizure.
Yeah, the fib seizure, right? Like, and the seizurelation. The first time you see it, right, your mind has to make this switch. And I think I used to have...
You're going to love this. You know where I was the first time I saw this? I was in an apartment in Yonkers, New York as a paramedic. And I'm like, it's just oh, that's not a seizure at all.
That's
this is
not a seizure.
Good. Yeah. That's a dance move.
But, and everybody, right, and everybody's gone, and not everybody, but a lot of people, you've been dispatched to a seizure. If you think about that kid case, right, they got dispatched initially to a seizure and then realized it was a cardiac arrest. Because when I get dispatched to the seizure, the only thing I really know is that there's somebody unconscious. They may be stiff or shaking at some point, right? Like, that's the only objective thing that I have when I'm dispatched to a seizure.
Now, one thing I want to do, because before this video airs, Allison and Daniel, you know both of them, are doing a thing on the definition of syncope. So the concept here about thinking about this in terms of seizures is not about the definition. It's about making sure you're not missing something. So just want to make sure we're not too confused about what Allison and Daniel are talking about. What you got with The Lancet?
Yeah, so this is a video that you're about to watch, is actually a video from an EEG lab. And the reason I have this is I used to have this preconceived notion that, because you learn a lot about those tables, right? Like, how do you tell the difference between syncope myoclonus versus a seizure? And we have this idea that if it was like very brief, then it was probably syncope. But if it was really long, it was probably a seizure. If you immediately returned to consciousness, it was probably syncope, right? And these are semi-predictive factors, but they are not black and white rules. And I used to think that if someone went into torsades, like, they needed assistance to get out of it. Like, you don't go into torsades and come out of it.
Much like hypoglycemia.
Yeah, without and this was this notion that I had. And then I saw this video from The Lancet. And so we're going to watch it together. And I'm going to give you a little bit of orientation to what you see in the screen. Okay. Oh. All right. All right, so here what you're seeing here is the bottom line is the EKG tracing, so you can see that, and the top lines are the brain waves on EEG. And this is a young patient who's now in the EEG lab because she's had recurrent seizures, and they're capturing this. And at the time, where the patient is actually not where the EKG monitor is. That is like in the control station. So now watch. Now what just happened? Oh, that's an interesting rhythm.
She's hitting the uh-oh button.
Yep, like I'm having a seizure.
Good.
So we can look at this rhythm. And that looks a lot like torsades.
Yeah, twisting at the points, right?
Okay, now watch what's happening to her cerebral perfusion. Right? Her brain waves are going away. And I think we can all look at this and say if we saw this, what I would think this patient was having a seizure.
A spell.
Yeah, a spell. So they're in there and they can't see what's happening on the EKG.
Interesting. I would hope so. That definitely does not seem like an appropriate response to torsades if you know that's what's going on. Yeah, interesting. So I think most of us who are looking at this rhythm, we're doing a bit of twitching too as we're looking at this.
Yeah, look at what
we should probably be doing some
And the
things.
brain waves look, if they were cardiac, asystolic.
Thank God they're not cardiac, right?
Yeah.
And don't feel bad if you don't know how to interpret EEGs. I don't either.
But I can interpret a flat line.
That does seem bad. Yeah.
They called it suppressed.
Seems like a euphemism.
Okay, now you see her breathing, and we would describe that as agonal.
Or not.
Now it's not. There's a
Yeah,
couple
yeah.
agonal breaths, and now she's not breathing. Now she's like...
This does not seem like normal seizure activity. It's interesting how the EEG or the ECG is progressing through this, because we don't usually get natural histories of what happens with torsades when you just ignore it.
So now they're like, something's wrong. We're going to be alarmed for the nurse. Right? And now she just has straight agonal breathing.
Yep.
Don't worry, we're not going to watch her die, okay? We watched
right.
her die, but
We're
we're not
open the
going to watch her
airway.
die permanently.
This is good. We're opening the airway. It's a good step. Feeling for a pulse might also be helpful. But
Now they're getting nervous.
yeah.
And just like I want you to think about the time.
Yeah. So it's interesting, the ECG is being recorded in another room, but it's not being monitored apparently.
Yes, this is actually one of the things that changed the practice of whether or not it's in the same room.
Right.
Okay, so now watch this. Look at what's happening in EKG. Boom, she breaks out of torsades.
What did the new woman who came in?
She just turned her on her side.
Oh, it
They didn't
almost
breathe.
looked like she did something. I can't see it.
No,
very-
she like
okay.
literally just turned her on her side.
Okay.
They did not get out of BVM, but look what happens.
Yeah.
She gets back in
It's
an
an organized
rhythm with
Yeah.
generalized slowing, and it's going to come back. So without the EKG monitor, anyone would have watched this and say, this is a seizure episode where they experience apnea during the seizure, which is not an unexpected thing if nobody feels for a pulse, and now you see this come back. So my assumption is, right, I had all these rules in my head that said, okay, if it was a 5-minute long episode where they had this, maybe that plus or minus apnea in a seizure, but she came out of it and she's confused because she was dead for a little bit with no brain perfusion.
I'll spot her some confusion.
Yeah, we would say, oh, that sounds definitely like a seizure.
Sure.
But now we have the EKG, okay, that shows this is a young girl who had prolonged QT,
Yeah.
who had recurrent episodes of seizure, which is how she ended up here. And her recurrent episodes of seizure were recurrent episodes of torsades.
Wow.
Right? And this is a time bomb for
Yeah.
when she does not break out of
Yeah.
torsades. And so I saw this, right, and it challenged all the assumptions I have in my head. And there are young people who I've seen for seizure in the ED, and I have personally caught cases of genetic prolonged QT syndrome in people who presented as a seizure, because you can't, the only thing I can assume when it's a seizure, right, is like, and they're like, oh, they had incontinence. Like, you've been seeing a lot of cardiac arrests. There's a whole lot of incontinence, right? Incontinence that happens.
Absolutely.
And so to me, right, like if you think about this opportunity, right, somebody may not put 2 and 2 together, and we'll talk about like this is kind of the Swiss cheese effect.
Yeah.
But if you do the EKG and you say, her QT is 540.
Right.
I'm worried that this was a cardiac problem. That has the potential, right, to change the course.
Yep.
And this girl gets a defibrillator. And even more, when you diagnose a there's a move, like within our region, for pediatric cardiac arrest to do genetic testing, because when I diagnose a genetic disorder, I don't just save
that
them.
Patient. Exactly.
I can save multiple members of that family. A lot of these are autosomal dominant disorders. Okay. So the next one we're going to talk about, that is a channelopathy. That's how they say it in Texas.
Apparently it is. I'm way too old to say that, but
Right.
I try to be young.
So prolonged QT, the first 2 that we're going to talk about are channelopathies, right? So they're mutations in channels. And Brugada is predominantly sodium channel mutations that affects how those sodium channels depolarize. There are a few other that are potassium or calcium channel, but they're all like essentially cardiac ion channel mutations. And the interesting thing here is that we'll talk about the findings of Brugada. For a lot of these, you think, oh, it's a genetic mutation, okay? Like it's gonna show up when you're 10 years old. Brugada can show up when you're 10, but usually the people who suffer a sudden cardiac arrest are like 40. And so, as I said, my background is in genetics. There's lots of genes that change their expression over the course of your life. Like, do you know anybody who developed lactose intolerance, like in their life? Like they didn't start out we don't start out lactose intolerant as babies because that would suck, right? Like
probably wouldn't live long enough to reproduce if that were the case.
But normally, those of us who can actually tolerate lactose are the mutants. That is a genetic adaptation to be able to tolerate dairy products as you get older. So like there are people who have lactose intolerance, which is actually normal because back when mammals were growing up, right, it's actually normal to stop expressing the genes that allow you to tolerate lactose. So there's change in expression of these, and that's why they may have had an EKG once, and there might be a subtle finding, but it's also something that they can follow, but there is a genetic disorder with this. And in Brugada, there's multiple types. I'm going to say, like, some of these you're going to see that on an EKG and say, oh, is this Brugada? And Brugada is really, like, there's a lot of false positive, but it's in the story plus the EKG.
As with most things, ECG by itself.
It's right, the differential diagnosis of the story and the differential diagnosis of the EKG as like Venn diagrams, and the path forward lies in the middle. Type 1 is this coved type, and that is the most specific. Brugada is an incomplete right bundle branch block in leads V1, V2, V3, the septal leads with cove type ST elevation. You can have this kind of saddleback type ST elevation. That is less specific, and you're going to look at this and say, oh, I see a lot of incomplete right bundle branch blocks with kind of this, but it's right in the story, and the question is this somebody who experienced syncope, right, who had this? But if you see type 1, like that is, very often what happens is your monitor says it's a STEMI, because it's reading, there's enough ST elevation. And this is an example, it's actually a real patient that I had, right, who came in with syncope, and this is their EKG, and the first thing, right, like you look through and you're like, oh, they look like normal, and you think it looks ischemic. Yeah. And so you can...
Well, it's your brain playing tricks on you, right? The most common thing you would see would be ischemia, therefore that must be ischemia.
But you'll see it's this wide, and the reason it's wide, it's a sodium channel blocker. And if you think about this, like if I had a sodium channel blockade, like if I overdosed you on amitriptyline, one of the things that you can see is right axis deviation, the R1, R prime in AVR, these incomplete right bundle branch blocks. It's the same thing because the majority of these are sodium channel mutations. It's a mutation that's mimicking sodium channel blockade that changes the way the cell depolarizes. I always thought about it as, right, like I could ski down that.
Right.
Like there's not too many things where you're just like, oh, I could speed down that curve. That's how I think about Brugada. So these first two, prolonged QT and Brugada, are both genetic abnormalities that can have variable expression in life. Prolonged QT usually presents earlier than Brugada, but they affect the way things depolarize and repolarize. And there's lots of different mutations. And I think the important is I can have a mutation that has a little bit of effect, and let's say I get, like in prolonged QT, like nausea, vomiting, diarrhea, and my potassium gets low, and there'll be a synergistic effect between those things.
Much like the medications that prolong QT. Maybe one alone doesn't do it, but now you get put on 3 or 4, and you throw in a mutation to begin with, and now that may be enough to
that might be enough to cause the problem. Or it's kind of the same thing. It's like, in general, I think it's totally safe to give like droperidol or things to everybody. But if you're coming in and you're like...
Was that $20 I agreed to pay you if you mentioned droperidol?
I love droperidol. You know, droperidol is the first medication I ever ordered as an emergency physician.
Is it really?
Yeah. It was like my like...
No wonder I like you.
Yeah, it was literally the first... I still remember, was it 0.625 or 1.25? Like, what's the dose?
It's not
enough.
I
remember. Not enough.
Love it, love it.
But just like, for the most part, I'm like, I can just give it, right?
Yeah,
like, I'm not super worried. But if somebody tells me the story that they've been like pooping their brains out for 3 days straight and vomiting for 3 days straight, that's the person I'm like, pause, let's get an EKG and see. And like, if they're starting... QT is like 520 because their potassium is 2, like that's not the patient I'm giving droperidol to just yet, right? So like it's all in there are things I'm like, yeah, generally safe, except you still got to get a clinical history and say, is this the right person? You still got to think.
Yep.
So this next one is a case where it is a genetic disorder, but it's a genetic disorder that actually affects the structure of the sarcomere, the muscle cells within the heart, and where they kind of get hypertrophied and large. And this is hypertrophic cardiomyopathy, also known as HOCM.
God bless you. I was waiting so long to use that, and you just weren't saying HOCM, so...
And
we're going to
talk about a few different types of HOCM, but the one that tends to present with syncope is one that causes thickening of the ventricular septum. And this is the classic when the next time you're doing a standby at a football game in Texas where it's a bajillion degrees out, and you say, oh, they were just dehydrated.
Right.
Okay, I want the pause here. So if we think about what a normal heart looks like, in HOCM, you can have this asymmetric thickening of the ventricular septum. And what happens there is I'm going to show an echo here, and I'm going to explain what you see here. But this isn't actually an echo of a patient who have what's called SAM, systolic anterior motion of the mitral valve, which is a fancy way of saying that, right, when the left ventricle contracts, right, so normally if you think about what happens is in diastole, right, the mitral valve opens, it lets blood from the left atrium into the left ventricle, and then during systole, that mitral valve is closed and the ventricle contracts and the blood shoots out the left ventricular outflow tract. When you get this thickened septum, what ends up happening is that those things are really close together and you get a vacuum that's like, it like pulls the anterior leaflet of the mitral valve into that ventricular septum and causes an obstruction. And if I have the anterior leaflet of the mitral valve blocking the outflow tract, that presents as brain doesn't get out, like blood doesn't get out, it doesn't get to my brain, and I'll pass out, right? Like that is the natural response. So I'm going to show a video of this, and then I think it's worthwhile thinking about, well, what would the impact of dehydration be on how, right? Because all of these, we act like every process is solid and it doesn't change over time and it doesn't change on their physiologic condition, but this definitely does. So what you're going to see here, over here on the right, that's the left atrium, and this is a very hypertrophied left ventricle. And what you can see is when the left ventricle is squeezing, this mitral valve is coming out and touching the septum, and there is like a millimeter for blood to get through. So this, if you think about, if the left ventricle is very full, the probability that this happens is less, right? Because those things aren't as close and the vacuum isn't as strong, right? So if somebody gets dehydrated and their end diastolic volume is lower, right, like the amount of volume in the heart,
Right.
the probability of developing clinically significant systolic anterior motion of the mitral valve increases. These patients will actually have dynamic murmurs. Like if they're dehydrated, or if they kind of like, if you squat down and you decrease, right, like venous return, you will have a murmur that comes and goes depending on your positioning. So now let's take the football player or the basketball player who's been running, whose volume down, right? And we say like, oh, it was just exertion.
Right.
But no, like the syncope is because there's a synergistic interaction between the structure of their heart and a problem that is worsened by dehydration. Actually, like when we had a SWAT officer go down and have actually syncopized, they had a VFib arrest. This is when I was, it was just before I was an EMS fellow, and it turned out he actually had undetected HOCM. So the question is like, why? This is why they present with syncope, okay? The question, why do they get VFib, right? Because
why do they get VFib?
Because this is what their cardiac myocytes look like, okay?
Is this from, please tell me this is not from Robbins.
This is from the New England Journal of Medicine,
very
okay?
Good. Suck it, Robbins.
So if you think about this is, right, there's a normal organized structure to the muscle, and
what we're looking at here is a microscopic slide where you take a really thin slice of muscle tissue, and that's what we're looking at, so you can get light through it. One of these is normal, one of these is abnormal.
Yeah, and you can see organized, right? And if you think the electrical circuits have to work their way through this, and when I have abnormal organization of the tissue, I have abnormal organization of the electrical circuits, and you say, if I had to be a betting person and said, which one of these looks like, if it were, some modern art, more likely to be associated with disorganized electrical activity, I think it's like, you don't even have to be able to interpret what you were looking like.
The one on the right kind of seems like if you asked Van Gogh to paint VFib, what it would look like.
Yeah, right? Like you can look at that and say, which feels disorganized to you.
I should get points for throwing in, a classy reference like
that
Van
was
Gogh.
pretty classy.
Not bad for a Texan, huh?
No. So let's think about the EKG findings, because normally when people think of hypertrophic cardiomyopathy, they focus on left ventricular hypertrophy, okay? And this is abnormal, right? Like in a young person who doesn't have a life of, we're so used to seeing left ventricular hypertrophy because people have lifetimes of hypertension to develop their LVH and diastolic heart failure.
We've earned it.
So people think about this, but note that you can have hypertrophic cardiomyopathy where the one part of your heart that's hypertrophied is your septum. Actually, some of the most dangerous forms, right, are the septum. So to think about the EKG findings, okay, I want to think about how the septum normally depolarizes, and you're going to be thinking about really, honestly, lead V6. So normally, right, it comes from my SA node to my AV node, and then as I go down the bundle, my septum depolarizes from left to right. And if I think about where I put V6, the septum depolarizes away from V6.
Yep.
So now when you look in EKG, you'll see like there's always like an itty bitty Q wave. It's not even Q wave.
It's also why we typically look in V1 when we're trying to identify the direction of a bundle branch block, which one, because that direction of depolarization across the ventricle toward V1 away from V6.
Yep. Right?
Nice.
So that's what we think about. So normally I hardly can see the septum in the EKG because how big something is a interplay of how much muscle mass is there and the distance between that and my chest wall, okay? Like to where I'm measuring it.
Right.
So.
Not saying anything about, the barbecue eating body habitus of your average Texan.
It's true, right? Sometimes it just looks like LVH, but they're just thin.
Right.
Because we're not used to it. We're not used to seeing it.
Pediatric ECGs just look weird.
So this is not clearly LVH. This is, though, a classic EKG for a patient with HOCM and septal hypertrophy. And what you're going to see here is if you look in V4, V5, V6, it almost looks like there's a pacer spike that's going down. That's called the dagger-like Q wave. And this is what
Nice.
like this is when I do my check, right? Like, all right, how long is the QT?
Yep.
I like V1, V2, V3. I'm checking for Brugada incomplete right bundle branch block with ST elevation. The first check, if I have like really obvious LVH, so that's one thing, but I'm always looking V4, V5, V6. I'm specifically looking for the dagger-like Q wave. And what the dagger-like Q wave is, the septum that you don't normally see, but that you see now because there's enough muscle mass that it actually shows up. Right?
I like it.
It actually shows up, and it looks like, you're like, why does it look like this kid has a pacer in V5, V6? That's the septum, right? Like, and this is why I'm like, if you understand the general direction of how an EKG works, you can actually figure that out, right? These are these dagger-like Q waves. There is another variant called the apical variant that is more common like Mediterranean populations where you have like a big thickening of the apex. They have less systolic anterior motion, but they're also at risk to have these VFib. And as we learned, not all VFib is permanent, right? We watched that video.
I think most VFib is not permanent. It doesn't stick around for long,
one way or the other. And I think if we think about the VFib that we see in patients with a critical coronary occlusion that are because there's inadequate perfusion versus these like arrhythmogenic things due to structural disease where, right, like something happens and then the electricity is kind of like, oh, turn the lights on and off, right? Like it had a reset. These patients are at risk for is the same VFib. And these look like they have these crazy, because the muscle is so thick, it almost looks like an LVH with strain pattern that we tend to see in people with hypertension. But I worry less about somebody missing this EKG because I don't even know, because it's like, ooh, that ugly, right? Like we're used to like looking at big, right? Like big, thick waves. But if you think back to those dagger-like Q waves, if you're not looking for them and there isn't clear LVH, that little thing is not going to pick it up. It's not going to say, oh, consider HOCM in this patient. You have to specifically look for it. It should.
That would be helpful.
But you have to specifically look for it, okay? So prolonged QT, Brugada, channelopathies, HOCM, structural heart disease. There's another type of structural heart disease called ARVD, or arrhythmogenic right ventricular dysplasia.
The dreaded ARVD.
Yes.
It's very common in pirates.
So this is a cut through the heart. This is
from Robbins?
I don't.
The only thing I know about pathology is that stupid book.
So this is the RV, right? So normally the right ventricle is 2/3 the size of the left ventricle. This thinned out RV, that's the RV in this case, and this is clearly a patient who died of ARVD. What you see in ARVD on the EKG.
You don't see a whole lot of path specimens like that from healthy people.
No. What happens is you get this kind of like incomplete right bundle branch block. And you get this little like divot called the epsilon wave and these deep, T wave inversions. And I think the important thing here is you can see a lot of incomplete right bundle branch blocks and little T wave inversions in young people, right? Like, because actually you'll see those kinds of things in pediatric EKGs, but these are deeper, right? Like these aren't benign appearing T wave inversions. These are quite a bit larger. And you're looking like you need a good quality EKG. So if you're bumping down whatever, like you won't see stuff. But if you can pick up the epsilon wave, and this is a diagnosis that can be made on echo, right? Like it's not normal and a lot of these patients really, right? They're going to get a PE workup because they have a giant RV, right? And they passed out. But it has to be considered of like, could they have a genetic disorder that causes this? So we've talked about channelopathies, right? Prolonged QT and Brugada. We've talked about structural heart disease, HOCM, and ARVD. And now we're going to talk about an electrical issue where it is kind of a structural issue where you have extra electrical tissue that you shouldn't otherwise have. You want to guess what number 5 is?
Have we talked about ARVD?
Yes, we just talked about ARVD.
Did we?
Yes. That was ARBV.
We did. Okay, sorry. This is what happens when I'm so fucking distracted.
I was like, did you have a... Well, that's why I gave you the...
I know, right. All right, so we did get the pirate joke in there. Yeah.
Do you want to re-record it without the pirate joke? Because...
Oh, hell no.
Okay.
All right, so we have the...
So
let's
I
just
can...
do this part over.
Do you know what the last one is? Do you want to look smart?
WPW?
Yeah, okay, good. Okay, do it again.
Any of the pre-excitations?
Yeah, really any of the pre-excitations. So we've talked so far about channelopathies that cause abnormalities in how things depolarize and repolarize. We've talked about structural heart disease that kind of messes with structurally how the electrical circuit works, and that can present with syncope for multitude of reasons. And now there's one more that is structural heart disease, but it's because you have not kind of disorganized electrical tissue, but some extra electrical tissue. What would that be?
Maybe some remnant fetal tissue, perhaps?
Yes.
Yeah, maybe some pre-excitation syndromes.
Yeah, the pre-excitation syndromes, the most famous of which is?
LGL, clearly more famous than WPW. Please tell me it's not something completely different.
It's WPW, but really these are the pre-excitation syndromes would be the most correct, because WPW is one flavor of the pre-excitation syndromes. And so I kind of try and think of this as, if this were Google Maps, right?
Yeah.
And thinking about how do things travel from place to place. And
you should probably use Apple Maps if you want to get there. But
Apple Maps. I actually use Waze now.
So WPW is what you get when you're using an inferior product such as Google Maps. Let's go with that.
That's totally true. Right? I use Waze, except that they would tell me that there's a bunch of potholes and police officers along the way. So,
potholes in New York. Who would have known?
Right. We reviewed this a few times, but I think it's important, which is if we think about how things normally happen, right? So SA node goes down to the AV node, and the atrial depolarizes, which shows up as the P wave. Mm-hmm. And then normally I use the highway system to cause rapid depolarization of the rapid and organized depolarization of the left ventricle, which is the QRS, okay? And so that's normally how things go. If I have a pre-excitation like WPW, and this extra path can be on the left or it can be on the right, what can happen is that I go the other way. So instead of going down there, I take a detour. And what happens is I actually kind of split and go both ways. Mm-hmm. And what I can get is I get this pre-excitation where some of it is not using the bundle of His. So it's using kind of the back roads. It's like a few of the cars are taking the scenic route, and I get a wide QRS. But my PR interval, which is essentially that pause at the AV node, also becomes short, right? Because there's some that aren't pausing. And so the classic findings in pre-excitation is I have a short PR and a delta wave. And because I didn't depolarize normally, my repolarization can be off, and I'll often have a T wave inversion. But really what I'm looking for is whenever I see a short PR is weird, okay? Right. There's not that many things that should have a short PR. We see long PRs, right? First degree heart block is a long PR. You'll see that all the time in people with high vagal tone, right? Who are super fit, or somebody who's on a beta blocker, but you don't see short PR that often. Okay? Yeah. You should be looking for a delta wave, which you may or may not see.
Yeah. And so I kind of think about this pre-excitation is your AV node's job in life is to act as a speed bump for this conduction from the atria down to the ventricles. And it works. We have patients with atrial fibrillation, so their atria are depolarizing at around 300 times a minute, but they're just cooking along at 70, 80, if they're medicated, 120, 130 if they're not, but not 300. So it's acting as a speed bump right up until you have a detour that allows you to bypass your speed bump. But when it bypasses the speed bump, it's getting on a back road that's moving slower. So you're depolarizing the ventricles, even though you got to the ventricles by getting away from that speed bump. You got there faster, but the depolarization is slower right up until it hits the superconducting system, and now things move rapidly. So that's the kind of the way I think about what is going on with this pre-excitation, meaning you're just
and sometimes,
bypassing
right?
it.
And sometimes we'll talk about their like manifest means I can see it on the basic.
Yeah.
But we'll talk about like there are people who can get other rhythms. So the most common thing that happens, right, is that people have a premature atrial contraction, and I get a reentrant loop, right? Because I normally don't have this loop where I can come back up
Yeah.
and excite this way.
Because of your light switch. Your light switch is not fully turned on.
It's not fully turned on.
So your refractory period.
And so the most common way that these patients present is they present with SVT, right? Like a supraventricular tachycardia. And really this is, right, like rather than AV nodal reentrant tachycardia, this is ARVT, which goes around. And when I'm looking at it here, like I can't tell if this is WPW or not. It just looks like a narrow complex, okay? And that's called orthodromic, which is that direction, ARVT. I can also have patients where it goes the other way.
Right.
And what that looks like when it goes this way is it kind of just looks like VTAC, okay? But that's actually an SVT, and that's antidromic AVRT. But both of these, right, they can present with these dysrhythmias, and everybody, for example, is afraid to give this particular dysrhythmia a beta blocker. And if they're in this rhythm, that's actually when you don't know that, right? Or if I give this patient like if I give the top patient, I'm unlikely to give this bottom patient adenosine. That would be bold. But the top one, if I give them adenosine, the reality is I'm going to break this, right? I'm going to break the circuit. I don't actually need to know, but I need to get the other EKG.
And the nice thing about this is if you go back, if you're like, I can't remember my dromics from my promics, I can, which by the way, I can't. One of these is narrow and the other is not. And that's where I default. If it's narrow, I'm probably going to be okay. I can do narrow things. If it's wide, the only thing I truly know right now, without just thinking about the omens from the chicken blood, is that's wide. The conduction is not going in the direction that it should. Something is aberrant about this. Maybe I should treat this rhythm different than the other ones.
And the thing that's really atypical here is we don't take care of that many 20-year-olds with VTAC. Right? So if you see to think differently. And these are and those are patients where I am more generous on the electricity side rather than the drug side, because there's some data that like amiodarone is good, okay?
And we don't tip it. The classic one we say you should use here is procainamide, but I don't know
who
many people
has
that
that.
care.
And who remembers the 17 milligrams per kilogram? Right?
Because I went to paramedic school when I learned this stuff.
Right?
Yeah. So here's the fascinating thing. We typically think that electricity is dangerous and drugs are safe. But we almost always get that backwards. The most dangerous part about the electricity is the drugs we give them so they don't remember the electricity. The electricity's fine.
So these are ones where like sometimes you want to consult somebody, but I need to think like it ain't normal.
Right.
Like maybe somebody has a channelopathy, maybe like amiodarone is not the best idea here, but it also makes you suspect. But these patients can present, right? Like I have a sudden heart rate of 200 that can present as syncope or tachycardia. And we actually had, and we'll talk about a case like. I'll talk about a real case that I had when I was a resident, but I also had a case when I was a medical director where this Grubhub guy comes to the door and the patient says, I don't feel well, immediately passes out. She initially has a pulse, like you can say it's really fast, and then goes into cardiac arrest.
Interesting.
She actually had, I looked at her EKG and they were like, it was like a VTAC, and it actually was not a VTAC. It was a patient who had an accessory, that poor Grubhub driver, but I mean, he saved, it's not, he didn't even get a tip, right? But
his tip was either an ablation or an ASCD? Well,
no, it was the person he was delivering to.
Oh.
Yeah, like he answers the door and she's like, call 911. Yeah, and they go plop, yeah.
Wow.
But she survived.
Grubhub dude did CPR?
Grubhub did CPR.
Tip your drivers, y'all.
Yeah, so I think the important thing here is that sometimes he's presented SVT, which you should always get like a post-cardioversion EKG on, and that's one of the reasons it's not to prove that they're in sinus. I can see that from a 3-lead.
Right.
Right? it's to actually look for these other reasons that are dangerous reasons that they went into SVT in the first place. But also, if I go to SVT and I pass out from my heart rate of 200, and then I vagal myself when I pass out, and I break myself out of my SVT,
you ain't in the rhythm anymore.
And you arrive, I am now a syncope case, not an SVT case.
Yeah.
Okay. So the really dangerous thing, the thing that kills these patients, is when they go into AFib for the exact reasons that Jeff was talking about, and that's because there is no gatekeeper. Or I think about this as kind of like the toll booth, and you have all these that go down at crazy rates, and normally, right, like people aren't walking around in VFib, but they're walking around in AFib, and that's because we have the AV node to thank for that.
Yep.
An EKG of a patient with AFib and WPW is unlike anything that you've, right? It's like, ooh, that crazy, because it's irregular and wide and way faster than anything else that you would see.
But there is ugly.
They're ugly. So this is actually a real case that I had when I was a resident working out at a community hospital. And we had a patient brought in post-ROSC who was young, like in his 20s. And the story was they get dispatched for an opioid overdose, and they walk into this house that reinforced their biases that this might be an opioid overdose. And this patient got a bunch of Narcan that did not, and then medics got there and put him on the monitor. And this was rhythm.
Interesting.
And they're shock that.
I don't know what that is. I'm going to shock it until I get to something.
I'm going to shock it. And they shock that.
Yeah.
And then I want you to look at this strip, okay?
Now, did they cardiovert it or did they defibrillate it?
I believe he was pulseless.
Going
like
that
they
fast,
couldn't
your
feel
odds
pulse.
are pretty good, but
I think he was pulseless. Like they couldn't feel pulse. I believe they defibrillated.
Okay.
Because they could not feel a pulse.
Fair.
And if you look at this, you're going to get a hint. Like this PR chart, you can kind of see a delta wave and a T wave inversion.
There.
And this was his EKG when he came into the ED. And if we take a look at it, the first thing, right, very short PR interval, and look particularly in like AVF and V3 and V5, you're going to see this delta wave.
Yeah.
So this
I like
young
lead
kid,
too. I like the little upslip there too.
this young kid had WPW, right? That caused, he had an episode of AFib with WPW and nearly arrested. And this is, he actually went, we admitted him, the cardiologist, he got seen by EP, he had an ablation, and this is post-ablation EKG.
Yeah.
And you'll see that it went back to normal. But when I was in the ED, I actually saw that he'd been seen in our emergency department for syncope.
Yep.
He'd been found passed out in a car 2 years before.
Oh boy.
And this was his EKG.
Uh-oh.
And do you know what his diagnosis was? Marijuana abuse.
Yeah.
Right? So this EKG was done.
He may have been smoking marijuana, but that is not.
That is not why he passed out in his car, right? He probably had an episode, honestly, of SVT or something like that had caused him to pass out in his car.
Yep.
So I looked at this, right? This kid came this close to dying, right? Like, for when somebody figured out to stop giving him Narcan and give him electricity instead, he was saved by that, and he came out neurologically intact and went on to live his life. But this was like a young guy in his 20s.
Right.
And so when people say like, oh, this is where the switch, they'll get an EKG at the ED. That doesn't mean, right?
We're going to catch it.
That we're going to catch it.
The more eyes on ECGs, the better off.
Right. But if somebody had come in and done the EKG and said, right, oh, this young kid passed out in his car, I'm in an EKG, and said, hey, doc, the PR interval, like it looks like he might have WPW, right? Like,
you think that might have had something to do with why he passed out?
Right, like it would at least, it has the potential to change that trajectory.
I like it.
So
we got 5 reasons.
5 reasons. And I'm going to say, like, you have to think about these 5. Like, if you have a checklist, my checklist is when I go in to document an EKG for syncope, I physically write it out.
Yeah.
Seen for syncope, EKG, normal sinus rhythm at 78. No prolonged QT.
Yep.
No signs of Brugada syndrome, right? No signs of hypertrophic cardiomyopathy, no signs of ARVD, right? Like, and I'll even like document those signs, and normal PR interval, and no delta wave. Like, I will physically, and the reason I do that
no dot
is
phrase. You want to write it because that forces you to think about it.
Because it's my double check, right? Before, and I do that because sometimes you're like, oh, discharge home, or like I do that as part of my discharge process from the ED. And it's a matter of like, if you can't remember it, right, then like put that on your phone somewhere.
Or maybe in your, just going to throw this out here, maybe put it in your protocols where you have little cheat sheets, just as a suggestion.
So you have it, but you have to think about those things because, right, like if you think about
What's
the
the
subtle
quote
findings.
about the mind not knowing what is it? The eyes don't see what the mind doesn't know.
It's true.
Go. That's it.
And sometimes it actually is a zebra. And I'll tell you what, if you look for them enough, I have found every single one of these multiple times with the exception of ARVD. And I don't work like in pediatrics or I don't work any of the things, but I have referral and I call the cardiologist. And sometimes I'm wrong.
Yeah.
And that's okay. It's totally,
there are two ways to be wrong.
I'd rather say, hey, this EKG
somebody.
looks funny.
Yeah.
And they say, oh, I think it looks okay, but very often like, oh, like refer them to echo, and it turns out that it's okay.
Yeah.
Then to send them home and find out that they, died on the football field, right? Like, this is a huge opportunity. And I hope at least with that other case where like this person had been seen in an emergency department, they'd had a 12 lead done before, and it wasn't caught. So like the more eyes, like the more people who are like deliberately thinking about this, and honestly, emergency physicians are often very cognitively overloaded. They're not looking at like one EKG at a time, right? They're getting a bunch of EKGs like thrown in their face from triage all the time.
And you're looking at one patient at the time. You can really help us out because our brains are slowly or quickly leaking out of our ears. You can help us avoid missing something that nobody wants to miss. So this is the reason we want you to get those 12 leads. So what are your 5 reasons, sir?
Right, so prolonged QT, right?
Yep.
Look for...
I like it.
You can look at the QTC or greater than 1/2 the RR interval, the Brugada syndrome, the incomplete right bundle with ST elevation, particularly that coved, like I want to ski down the curve. Hokum, where you're looking for those dagger, like there's one that looked really messed up. I'm not worried about missing those, but specifically looking for the dagger-like Q wave.
The isolated pacemaker syndrome.
The isolated
patient without a pacemaker.
Isolated lateral lead pacemaker, inverse pacemaker, right? Because I have Down syndrome.
Seems odd.
ARVD, where you're looking for this epsilon wave and T wave inversion, and WPW, where particularly you're looking for a short PR interval and delta wave.
I like it.
So I would be remiss if I didn't actually talk that there's a national quality measure on this, which is 911 requests, right, that look to see a 12 lead in syncope was performed. And I think very often when people, as I said, like people think about this and they think about the 65-year-old with syncope.
Right.
And I'm going to say that I am less worried about the emergency department not thinking about deadly causes of syncope in a 65-year-old patient who presents with syncope. Like their pretest probability of at least an OBS admission is already higher than when they're 16.
Yeah.
I'm thinking about like, how do I know that this is actually, the standby at the football game or the kid who passes out somewhere? Like,
do all athletes in New York have to get 12 lead? So that's a new law in Texas.
That is not the law in New York. And I think you can have that law and they have the screening EKG. But no, right? Like sometimes these things are dynamic. So I can have a slightly prolonged QT, and if I overexert myself and I get a little hypokalemia and I take a little bit of other like medication because I'm feeling nauseous with my gastro and I'm going to make it to practice, sometimes those things are enough to tip, right? Like tip people over. Yeah. And so it's still, right, like...
This is why we need to do the ECG on multiple ECGs, increase the likelihood that we're going to catch it and that somebody's eyes are going to see it.
That was great content from Dr. Dorsett. As much as I always enjoy having great and nerdy conversations with my friends, I'm particularly glad we got the opportunity to film this so I can bring her to Fort Worth, even if it's just virtually. I took away some important key learning points from her in that talk. She summarized it well, so I'm not going to do it again. I hope you got a lot out of it too. I think it is really good stuff. Now, up next, we're going to go to Dr. Miller talking about cold water immersion. Once you finish this video up, go do the things and then get around to clicking on that one. And until then, as always, thank you for your attention and for what you do for our patients every day. Take care, y'all.